Dr. James Metz, I am so glad to see
Thank you, Barry.
I'm so glad to see you.
I'm glad to see you too.
I'm looking over some of your resume highlights, and I decided that I don't want to take 30 minutes describing all your background. So is it okay if I just go through a couple of things? Would that be all right, since we're...
Whatever you think is important. I put it all there just so you would know.
Okay. So the main things I want to talk about is that, are you a Buckeye?
Yes. I was actually the team dentist for Woody Hayes.
Really? Really? Team dentist for Woody Hayes. And you graduated in 1973. Okay. And a lot of activity here. American Dental Association Scientific Investigative Committee Workshop. You also been involved in the Scientific Investigation Committee of the American Academy of Restorative Dentistry for sleep dentistry. Also a part of the American Academy of Dental Sleep Medicine Board of Directors, part of Course Development Committee, Public Relations, Chair and Vice Chair of various program offerings of the AADSM. You also founded, this one is very interesting. If you want to comment on it later on, please bring it into the conversation. Dental Interest Group of the American Thoracic Society. That's very encouraging.
That is the most important one.
And then American Academy of Restorative Dentistry, International Academy of Gnatology, and also involved, as we said,
you just have to get old, Barry.
Is that what the secret is? You're also doing some work, as you've mentioned to me previously, in the Republic of China, and you also got some ideas cooking for some research projects. And I don't want to forget that you're very interested in this whole area of wilchodontics for accelerated osteogenic orthodontic procedures. So much to talk about. We could go on for hours. We've got plenty of time, so make sure that you get to give us all the stuff you think we need to hear. And I think the first place to start really is, how did you get started in sleep dental medicine, if that's a good topic?
That's a great topic, Barry. If you want me to share my computer screen, I do have a program open behind us, my keynote, that has some principal slides in it if we want to show that.
We'll wait till later on.
Yeah. Well, it's interesting. Ever since I've been in dentistry, I've been interested in crown and bridge, advanced restorative materials. When I was in the Army, everybody let me do that because nobody else wanted to do it, and so I got to do the hard stuff. And what that led to was an understanding of temporomandibular disorders. And because we used to think that the occlusion was principal to causing joint pain, headaches, and whatever. And so you did a reconstruction or a lot of crowns, you didn't want to create a problem. So I got very good at controlling the occlusion of the bite. And as I moved along, I began to realize that it was not the bite. It wasn't the way the teeth fit together that was the problem. It was something else. I didn't know what it was. And then I got into this sleep medicine and realized that we clench our teeth just to protect our airway. And there's some ifs, ands, or buts there to talk about, but that's kind of the middle ground. And so with that, I started studying sleep, and it just opened up a wonderful world. I mean, it's the most exciting thing I've ever gotten involved in. It's really all I think about anymore. It's about all I work on. And I'm driving myself harder now than I've ever have in my life. And I'll be 70 in September. So I really enjoy this whole area of sleep dentistry, sleep medicine. And I think a lot of dentists are making a mistake with trying to do this on their own. This needs to be done with a physician because we have moved as a dentist into medicine. It's not medicine moves into dentistry, it's dentistry moves into medicine. And we're under the same guidance and criteria of other practitioners within the field of medicine. And so we need to learn to work together. Dentists are very lone wolves a lot of the time. That seems to be the principal characteristic of dentistry, because we work by ourselves in our office always. We're not used to a hospital situation. But we need a cardiologist. We need a gastroenterologist. We need ENT. We need sleep, especially, because we get into things that honestly dentistry should not be handling. But we've got this great method of doing it. And we can do the method, but we need the medical help to assure that the patient has a good outcome.
Well, let's talk about that for a minute, because I have a small disagreement with you on it. I put a post up at Classic Sleep Care just a couple of weeks ago. I don't know if you had a chance to read it. It's one of the ones where I mentioned, the Metz group and your organization in Columbus, Ohio.
All that.
I feel very strongly that because dentists spend so much time examining the oral airway, that it's not just that dentists are invading the medical space. I think the sleep doctors have a tremendous amount to learn from the dentists, and I don't think it's unreasonable for the dentists to eventually see themselves as primary sleep providers, because we both know that not everybody is going to be able to use a PAP machine. And there's plenty of people who might benefit from a dental device first. And because the dentists do so much in their exams of the oral airway, I see it more as a natural fit, and in a way where I'd like to think that doctors are going to want to collaborate with the dentist, not just the dentists have to go around begging doctors, to work with them. I think the dentists, and I've always said this actually ever since I met Tom Mead in Albuquerque back in the 1980s, the dentists have a tremendous amount to offer to this field, and they should not see themselves in what I would call a defensive posture, although you are correct, there are certain areas that medically, legally, we all have to be careful of anyway.
Oh, Barry, I couldn't agree with you more. You're exactly right. There's no disagreement between us there. The only thing that I would say that I have noticed is that it's hard for a dentist to move into the area where the patient's health is actually critical to their survival. We have always been in an area where we fix a cavity, we fix a crown, we make them look better. Right. But all of a sudden now, a properly titrated oral appliance can possibly add years of life to someone that wouldn't otherwise live that long. We did a study at Ohio State, and with an oral appliance, we were able on 25 out of 25 patients that were mildly diabetic to take them back to normal blood sugars with an oral appliance. And it's never been published. It bothers me that it hasn't. It was actually the first study I was ever involved with Yulie McGowan at Ohio State. Mm-hmm. And it amazed me that we could actually go after the physiology of the body so profoundly with an oral appliance. Dentists have always thought, keep people happy, so their wives don't elbow them or, from snoring, or, they feel a little bit better in the morning when they wake up and they're not tired and all that. But this goes so far beyond that. Right. The idea of I heard you speaking before we came on about inflammation. Inflammation, is set off by cortisol and in the body. And it could very well be controlled by an oral appliance very, very, very well. And so all of a sudden the inflammatory processes may actually be under our control to a higher degree than we've thought in the past. Take the oral appliance.
Jim, are you referring to that when you treat a sleep breathing condition, we expect to see a decrease in the inflammatory response in the airway? Or are you referring to something more systemic now?
Well, both.
Okay.
You know, for in the airway, because I think the inflammation in the airway mainly comes from a reflux problem. And as we keep the airway open, the reflux, and we teach them physicians, how to sleep, the reflux decreases. So the airway is the first inflammation to go away. But then what we've noticed is that we've been able to control the heart rate very well with an oral appliance, because decreasing the fight-flight response. And with that decrease in the fight-flight response, it appears, and there's been some papers that show this, but the numbers have been very low and they actually haven't been very well done, that shows the inflammation of the body decreases with the oral appliance systemically.
So then similar to when somebody uses, a PAP device, and some of the research that's been published looks at endothelial dysfunction, the lining of the blood vessel, and showing that there is improvement, clearly would go along, with that theory.
Right.
And then
we have
go ahead.
We have an endopath in the office by Itamar. And it's been really interesting to see the changes in the endothelial scores based on the endopat with the use of the oral appliance over time.
How is that test done? I'm not familiar with the endopath, you said?
Yes, it's used mainly for research. It's not really used clinically.
Mm-hmm.
What it is you put little blood pressure cuffs on the same finger on both hands. They're little tiny things, and very similar to the WatchPat. It's the same company, Itamar.
Right.
And what it is you also put a blood pressure cuff on one arm, and you go for 7 minutes and you measure the blood flow through the two fingers. Then you pump up the blood pressure cuff and completely occlude it for another 7 minutes. And you continue to record the opposing hand. And after 7 minutes, you release it and you measure how long it takes the arm that was occluded to return to normal. And that's a measure of the internal resistance of the vessels, and which is a measure of endothelial health. And it's worked out pretty well.
That sounds very interesting. And it gets into an area that is so important, which I know you have a lot of opinion on and ideas and experience, and that is how do we define success when people are trying to use OAT? Because obviously many sleep doctors and obviously many dentists, when they are comparing between CPAP and an oral appliance, mandibular advancement device, there's always the question of what is the true benefit of each one and how do they compare? Obviously, one of the biggest issues that comes up in all these discussions is, well, if you don't use your PAP machine, but you will use your dental device, then obviously the dental device is superior. And there's no argument there, because if you can't use a PAP machine, then we want treatment. We don't want no treatment.
That's right. Well, that's a big subject. The oral device is not mechanical. That's the one downfall of it. Like if you put a CPAP on somebody and you splint the airway, it's open, and they're breathing that night. It's pretty remarkable what a CPAP does. Oral appliance is very different. It sets up conditions for healing, is what I say, more than it really resolves it quickly. The one problem with the oral device is the change of occlusion or change of the bite. And it's interesting, you read through my resume first, and I've been involved in gnatology, which means the study of teeth. It is of all the disciplines of dentistry, it's probably the most involved with the bite. And I spent 25 years learning that and knowing it and lecturing on it and whatever. The first thing I did when I put a mandibular advancement device in is I always said I blew up the occlusion. I blew up the bite. And it's really something, because all of a sudden, all the things that I thought I shouldn't do, I was doing, and I was changing the bite. But what I realized is for every millimeter you move the jaw forward, you put 127 grams of force on the teeth. So the less far you move the jaw forward, the less dental problem, dental morbidity that you have. So, but the early appliances that I worked with really pulled the jaw out a mile. I mean, the patients, it was in their jaw was in the next room to get a decent outcome. And so what I started doing was playing around with the appliances and actually making them thinner, smaller, less intrusive onto the oral cavity volume. And as I did, we started not having to advance the jaw so far. So now we've come up to an average of between 6.5 and 7 millimeters of mandibular advancement will clear most people and we just are completing the study. We actually got 68.9%, if I remember correctly, of the patients to less than 5, and only took them out less than 7 millimeters. So the dental morbidity doesn't really kick in very strongly there. And that was help. But to do that, you have to get rid of the inflammation in the airway, which we talked earlier. And the first key to all this came from an ENT that I work with still today. And he actually, when I got the patient out to about 7 millimeters, on one occasion he gave them a steroid, a dose pack, and that really relieved the inflammation in the airway. And all of a sudden, my oximetry readings and everything just got 100% better. And so I realized that I didn't have to move the jaw completely forward to get the airway clear. I needed some help with managing the inflammation in the airway at a less of a protrusion. And with that, I got a remarkable outcome. And we found that as long as someone continues to wear the oral appliance, that inflammation does not seem to return. And we've measured up to a year after that one incidence of giving the one round of the medication, and the inflammation hasn't returned, which I think we haven't reported that, but I see that. So what it is the CPAP is very mechanical and works every time if somebody will wear it. It just does the job. The oral appliance is like tuning a Ferrari or something. It's all mechanical. You're moving the jaw forward, but the body doesn't know it's there. And so consequently, it doesn't trip any of the responses that I think CPAP may trip too. So it has a benefit there. But the body has to heal over time. And the first time I ever realized this was an older patient of mine. He's allowed me to use his name. So he said, use it, Jim, because I want this to get out as an information. You won't know it, but his name's Pete Dawson. And Pete is probably the most influential dentist in the United States today. He's, I've known Pete most of my life. And about 4 or 5 years ago, I made him an oral appliance. And his apnea index was off the charts. He was extremely severe. And what scared me, and the reason why you've got to be careful about this, is I put the oral appliance in, but he did not want to work with a sleep physician. And that made me extremely nervous. I didn't like it because he was extremely severe. Well, I put the oral appliance in and I tested him, and then I tested him again about 3 months later, and he was in pretty severe Cheyne-Stokes respiration. He was really, SpO2 was just up and down, uncontrolled. And I thought, Pete, I said, this is beyond me. We really need to get somebody else involved here. He said, no, I'm not going to do that. I'm feeling better than I've felt in 10 years, and I'm fine. So I let it go. And I thought, oh, I wanted to have a success with him. This is the man I hold in probably the highest esteem I can imagine of another dentist. I mean, he's been remarkable to me. And I've learned a ton from him. And so he practices in St. Pete. And so the next Christmas, I went down and met with Pete, and I did my adjustments and everything that I do. And I use a lateral ceph, which is unusual. And I even had a hard time finding a lateral cephalometric X-ray machine in St. Pete. Mm-hmm. You tried to use CBCT, cone beam, and that doesn't work. But anyway, I finally found this old ceph. We got him all titrated. Everything's fine. And he said, Jim, would you please give me a pulse oximeter? My grandson needs to be checked. I think he has this same problem. So about a week later, I got it back in the mail and I downloaded it. And it had an apnea index of about 8. Some DSATs, the SpO2 wasn't real stable, and the heart rate wasn't perfect. And I thought, well, it looks like a young Pete is what it looks like. And I thought, well, this 20-year-old's not going to want to wear an oral appliance or have CPAP or anything. What am I going to say? And I always want to please Pete. I mean, I always want to give him the right answer. And so I called him up and I said, Pete, I got your grandson's pulse oximetry downloaded. And he says, what do you mean, my grandson's? And I said, well, I gave you the oximeter for him. He says, oh, Jim, he wouldn't do it. That was mine. And he went through Cheyne-Stokes, all the way through from severe sleep apnea to Cheyne-Stokes to relatively normal, less than 10. He was about an 8 AHI. But all the Cheyne-Stokes had resolved. And it amazed me how with that, it tells me the oral appliance takes time to heal. So somebody that thinks an oral appliance in 2 weeks is going to knock it out of the park is really wrong on these severe patients. If you're working on a 20 or 30-year-old patient, maybe that's true, but not on the severe apneic patient or the ones that have had it for a considerable time. So you need to set up, I think what the oral appliance does is sets up conditions for healing, and you got to let the body go. And that's the reason why you need to work with a gastroenterologist if you're having trouble with the GERD. I wanted him to see a cardiologist. I wanted to work with a sleep physician. It was way out of my league, I felt, because I get to thinking that what I did was very similar to what the ASV units do. And I know the problems that have been there, and I don't know whether I created the same situation as a ASV unit or not. So it made me worry.
Well, there has been at least one published case report of somebody developing central apneas after starting with an oral appliance, but I don't remember the pathological mechanism that they were describing. Let me ask you, when you talk about this timetable, remember with PAP therapy, as we've published on numerous occasions, you don't just get the perfect pressures the first time you do a titration. There is, as you say, the healing and other adaptation issues. And so over time, people return for retitrations, the pressures are adjusted. In terms of the dental device, what are some of the ways in which adjustments occur, and over what timetable based on this idea you're talking about regarding the healing?
Well, the protrusion is the major one that everybody talks about, how far forward you move the jaw, how far forward you move the mandible. But what that is, patients can only tolerate a certain amount of forward movement. And they get sore, they go into TMJ pain, they all these things. And I think the reason why I've been so successful with this, I'm very comfortable with TMJ. If I get them into a TMJ problem, I can get them out of a TMJ problem. And so that is not an issue. I can, and sometimes it's a fine balance of playing with it to get them kind of over the hump with their TMJ issue, to get the oral appliance to work correctly. And so I go through that, and that's the first one. And what I found,
but when you do the original protrusion, then are you saying that that is done in a graduated fashion? In other words, you don't go to 7 right away.
No, most people can't. Some people can tolerate that, but not many. What we found that you usually can get by with is going halfway forward. In other words, to 3.5.
Okay.
And then usually you can go on to 7 after that, after about 3 or 4 weeks, and have the adjustment pretty well completed. But that's not true for some people. I've found that there's a group of people that works for, and that's probably about 80% of the patients, but there's about 20% of the patients that have this whole other bag of problems that are not related to the protrusion. What we found is the vertical, in other words, the one that goes up and down between the teeth, becomes very important too. And a lot of the appliances are so big and so thick that they've actually taken what's called the vertical dimension beyond the range of tolerability of most patients to start with. We found that most patients want a fairly mild amount of vertical, and that helps. And then you get into that. The GERD is the third big issue. Then you get into breakage of the appliance. You need to have a robust appliance, but it can't be big and heavy and thick. It's got to be strong, but not bulky. And a lot of the appliances are bulky.
Right.
And then it gets into the patients too and their habits. One of the problems with an oral appliance that you don't have quite as much of CPAP is alcohol and drugs, because alcohol will absolutely knock the efficacy of an oral appliance out the window. If they get bombed, I mean, oral appliances don't work well. So people that are bad alcoholics, or even always have a drink right before they go to bed at night, are not going to do well in an oral appliance, and you're never going to get their numbers down where they should be. So it becomes a lot. Then you get into the allergies and dogs and cats sleeping in the bed, and all those kinds of things are an issue as well. But when we just bought a really fancy new CBCT. It's a extremely low dose. It's a Plan Mecca that we can actually scan the nasal cavity pretty well. And we've referred more people to ENT in the last 4 months than anybody into this one very large healthcare system. They think that they think I'm wonderful. I've sent them patient after patient after patient. And what's really interesting is the nasal problem is always there in the beginning with an oral appliance, because I think the GERD, you acidify the air and it goes into the nose and causes swelling. And as you get the oral appliance straightened around and get it adjusted and more toward the normal titration, it seems like that goes away and people turn back into nasal breathers after a while. But there's a group of them that absolutely do not. You know, they have the deviated septums and the large turbinates and all that thing. And we had those, we've had those taken care of, and that has dropped people's apnea-hypopnea index dramatically, along with the oral appliance.
Right.
The two together are the...
Right. We use the ear, nose, and throat doctors religiously as well. One of the things we've been noticing over the last several years is there's not just the GERD, but there's a lot of non-allergic rhinitis in these patients. Some of it could be provoked by the GERD. Some of it is its own independent process. So we've been surprised how many patients respond to the non-steroid sprays. For example, the azelastine antihistamine spray or the ipratropium Atrovent spray. And many of those patients will see some calming down. And so it's so important, you know, that many of these people do see ear, nose, and throat doctors. Sometimes it's allergists and so forth. But do you want to comment now on some of the more intricate ways that you said come into play beyond the protrusion? You mentioned the vertical, and the vertical is very important. I think you and I have actually had conversations about this before where I mentioned that one of the things that can occur is if you do have too much vertical, you literally get a bit of a jaw drop and the tongue will start falling backwards. So that's why I've always been concerned about it. And that's what the last time that we met, I asked you about what do you think of the devices that allow the tongue to slide forward and actually have a space versus the type that run up against the barrier, of the dental arch created, by the dental device. So any specifics there that you think dentists who are listening to our program, they would probably have a better appreciation for this than I would, but I'm curious if, without revealing too many of your secrets, if you have some ideas on what are the other adjustments or manipulations that the dentists need to be thinking about besides the protrusion?
Well, it's interesting. If I see a normal dental device, I take a what's called a carbide burr in dentistry, which is I've got one called the Terminator, which is highly, highly aggressive. And I go after that appliance like crazy, getting rid of excessive plastic. The technicians tend to make them too big, too bulky, too thick because they don't want them to break. But it's interesting, if you make them big, bulky like that, there's the ones that tend to break because you're infringing on the tongue too much. So I always uncover and let the tongue come out through the front.
And there's still many devices that don't do that.
Tons of them. And see, there's no real consensus on even what's called oral cavity volume. The idea, I always am trying to maximize how much room there is inside the mouth. That's what my goal is, within a reason, and you brought it up with the vertical. But so if you've got a little bit of plastic there, I always say the tongue will take advantage of any space that it has. And if you get 2 cells out of the throat and into the mouth, because the tongue can only be in the throat or in the mouth, one of the 2 places, and if you can give it 5 more cells in there, the patient is better off. Mm-hmm. And but the interesting thing is the only way you can really evaluate an oral appliance. And one of the controversies right now is with dentists using pulse oximetry or any kind of monitoring device for, to titrate or to adjust the appliance. And in the beginning, everything is a guess with an oral appliance. So what we do is we set it to a certain amount of vertical, we set it to a certain amount of horizontal, and then we get it in what I consider the normal ranges. And every appliance has a different normal range. There's no normal. Every appliance has like its own fingerprint. Mm-hmm. If you have more plastic in the palate, the advancement will not be 6.5 to 7. It'll be 8 to 9 or 10. Or if it's thinner or it's not there at all, maybe it'll be a 5. But I haven't figured out how to make it not there at all. So it really, depending on the bulk, it sets the horizontal. But the interesting thing about it is you get out to the normal ranges, and this patient's worse or not feeling better, or and so you look at the pulse oximetry report. So what do? Normally a dentist cranks them forward more, mm-hmm. and they get even worse, and they get more uncomfortable, and they don't like it, and they complain a lot. Mm-hmm. So what we had to do was put an extra step in there. And what we use is the lateral cephalometric film that's been used by really orthodontists since probably back in the 30s. And it shows a lateral view of the head like this. Mm-hmm. And the beauty of it is that can be taken in an instantaneous basis. You can catch it. So we take it, the patient, there's a little bit of a protocol to it. And anybody that's listening to this that wants this protocol, I'll be glad to email it to them. But you breathe out all the way to the bottom of the breath. You're standing up straight, teeth together, and you take an x-ray. And it's taken in a split second. And you can't do that with a CBCT. And what that does, it shows what the oral pharynx looks like with the oral appliance in place. We have one of those to start, and we have one at C6.5 if they're not doing well. Now, did we make that airway bigger or did we make it smaller? It's all relative. I realize the patient's awake and standing up and all that stuff, but it's relative. If I make it relatively bigger, they're probably bigger. And so what I found is by varying the vertical, the maximum vertical we ever use, and we define it over the premolar area, right here, over the bicuspids. That's where we define vertical. The maximum we've ever done on a patient was 6 millimeters. And many of the appliances come in thicker than that from the laboratory for even small women. And small women have I always say they're like a Swiss watch compared to a grandfather clock on a 6'5" guy. But anyway, you change the vertical by 1 millimeter, and sometimes you'll open up the posterior airway space by as much as 2 millimeters. So you adjust the horizontal out to get into normal ranges, and then you start playing with the vertical, open and closing it, and see what makes that airway bigger. And so that is our second data point. Our first data point was the pulse oximeter telling us whether we were good or not good. The other data point is it shows us what the airway actually looks like at an instantaneous point in time. And then we start playing with that, with the horizontal and the vertical, till we get somebody straightened around.
I like to find practical steps that a patient can try that might convince them of why they would go down this pathway. For years, I will have patients put their lower teeth in a forward position and then go back and forth. If I say, put your mouth out like that, but don't get all this tension, just hold your teeth forward, then put them back. And most people who do that will say, oh, I notice that I can breathe better through my nose when my teeth are forward. And I'm wondering, do you ever use tools like that with the patient? And if so, is there anything about this vertical that can be used in that way where a patient would be able to try it and be able to sense? Because it seems like there's got to be some, I don't know how quantitative it is, but qualitatively, it's been so consistent when people thrust their jaw forward without tension, just hold it into a thrusted position. Most people will say, I can breathe better. I can breathe better through my nose.
That's really absolutely correct. And we do that, Barry. That's the quickest trick that I know of. A lot of dentists, though, are going down a path that I don't think works, and that's using temporary appliances and saying that they're similar to the custom-made appliance. They just absolutely are not. They bear no resemblance to a custom-made appliance. And people are selling that pretty hard, because you don't vary the vertical, the horizontal, and sometimes it turns people off that could be fixed with an oral appliance but don't think they can be. And I know some of the insurance companies are starting to use that as well before they will pay for a mandibular advancement device. But what I liked about it is, and I'm really proud of these numbers, we did 101 consecutive patients, and we'll soon publish this. But of that group, 69.8%, we got to less than 5 with an average age high of around 29. We had high BMIs too. The median was over 30. So they weren't people, and everybody was 85% were CPAP intolerant. That we took care of. We didn't get first crack at anybody hardly. But what I really liked, less than 5 is pretty strict criteria, but that's what we want to go for. But for less than 10, we got 78% of the people to less than 10 with the oral appliance. But the one that I really liked, that I thought you can tell people pretty predictably, we got 98 people out of 101 to have a greater than 50% improvement. And so the idea that oral appliances work but you got to work with the ENT. You've got to control alcohol. You have to demand something of the patient. If I go back to Pete Dawson, he's a unique man. He has always said that if you're going to evaluate my technique, you must do it exactly as I say, or don't say that you are evaluating my technique. You know, you have to reproduce it. And he has been incredible on getting the bite correct and how he goes about doing all this. It's really masterful work. Well, when I asked him to start wearing the appliance, he said yes. He has never gone without that appliance in 4 years. Never. And see, you get a compliance out of a patient like that. And so it's led us to realize that there's 3 groups of patients. I call them our A-listers, our B-listers, and our C-listers, kind of like Southwest, you know. And the A-listers do exactly what you tell them. They come in for their appointments. They allow you to actually treat them. The Bs, they come in sometimes they don't. The C's, you just sell them an appliance, and you know the success rate is totally haphazard. It's relatively predictable with the ones that come in now and again, but to get real true success with an oral appliance, you need to be them to be the A-lister and come in. When we're going through this, and I do have an answer for this when I get all done, but when we went through this, we had an average of 17 nights of study on each of these people in this 101 group. Well, what it did, it caused several people to drop out because they wouldn't get a clearing PSG, they wouldn't get a clearing HST on the end. They basically did what they wanted to do, so they weren't part of the trial. You know, so we lost this group of people who were relatively non-compliant. That's one of the reasons why our numbers were so good. Because they just wouldn't cooperate with the trial. And so anyway, if you get a compliant patient and they'll work with you, you can have, the same way as CPAP, you can have a really wonderful outcomes with that group of patients. And so we try to tell them that. We have them call other patients to tell them what their success rate was if they're not doing well. We actually have created almost like a little support group, you know, for people with oral appliances, and through that means we've gotten good outcomes. So in a way, what I tell people, just one more thing. I didn't get to my point. What I tell people is, if you work with us, you're going to have a success. And if you don't work with us, I don't know. Yeah. So, you know, what's your feeling?
Right. Yeah. You know, that very much parallels PAP therapy. You have to be able to use the PAP
right.
to get it. Now, any other points, though, on that idea of anything that the patient can do just in the very beginning phases? You mentioned that you don't like the idea of those temporary devices. Is there anything else a patient can do besides practicing the jaw thrust that will give them not only an indication, but some confidence of, oh, I think I want to do this because I get the feeling this is going to work for me? You mentioned you do the jaw thrust. Anything else?
Yeah. The other thing is positional therapy. You know, sleeping with about 14 to 16 inches of elevation on their head and on their left side. That really helps because there's less GERD on the left side than there is on the right side because of the position of the stomach. And that seems to make people feel better too. And if they start doing better with therapy like that, that's a big help. The other thing is some people come in and they have dental devices, and a patient will be told, you got to wear your denture every night. And so they're wearing their denture every night to bed. So what I did is I said, okay, wear 3 nights, and I always do 3 nights to screen out changes in night-to-night variability. And anyway, they wore their upper denture for 3 nights, and 3 nights they didn't. So which way were they the best? by far the best without the denture.
Right.
Now, that may be different for other people. Everybody that we've tested is better without their denture than with their denture. Another thing is oh golly, what else do we do? I guess positional therapy, and then sometimes getting people off their stomach is a big help because they get so much hypoventilation if they're laying on their stomach at night. And we can tell so much. But, I think the best thing, coming back to it, I hadn't thought of that question for a while. The very best thing we do is we take that lateral ceph and we show the patient their airway. And I put my thumb over top of it and I say, your airway should be the size of my thumb. And it's the size of a tiny soda straw or anything at all. Mm-hmm. And then I show them where the hyoid bone is, and I show them what we're going to do is move the jaw forward, and there's a muscle that attaches the two. So we're going to be able to pull that jaw forward by about 6 millimeters or 7 millimeters or 8, very predictably. And so your airway is going to get bigger, and I show them that.
That's very motivating.
It is. And the interesting thing, I got in trouble on this. This was funny because that jaw thrust, I took a lateral. Now our X-ray machine is extremely low dose. I mean, it's the newest of the new that. But what I did is I had the patient thrust their jaw forward, and I took another lateral ceph to show them the difference in the airway. Well, the airway gets massive. I mean, it gets the size of a garden hose. But what's interesting is if you put an oral appliance in and you pull it forward the same 7 millimeters, say, what happens is you don't have the activity of the muscles like you do when somebody thrusts their jaw forward like this.
Right.
What happens is you pull the jaw forward and all that tongue tissue gets pushed up into the back of the throat. And so that's the reason why we found we had to have vertical to be able to work with these. You have to put that tongue somewhere. Is what my saying is where we're going to put it. Sometimes you can't open the vertical too much because their jaw angle is very high and it swings back against the back of the throat and collapses it, like you were saying. Sometimes you can only get by with 2 millimeters. Or 1.5 millimeters. That's all you can. Then other times you can get 5 to 7 or 6, not 7. I've never gotten 7. And it's kind of like playing around. I hate to say it, but when it comes down to it, that's what you're doing with these things.
When I went to my first Dental Sleep Meeting Society, which was almost 25 years ago, I remember that's where I learned at the time, tell me if this is still valid, that the natural resting place for the tongue should be on the roof of the mouth.
That's exactly right.
And so I've always wondered then, how does that play out with, going back to an earlier question I had for you, how does that play out with the dental device where on the one hand, if it's too bulky, it probably can't get to the roof of the mouth. If it's got a hole in the space between the two arches, then it can actually slide forward. Is there an ideal place for the tongue where it should be slid forward, or should it actually be on the roof of the mouth? And does that depend on the type of dental device?
It does depend on the type of dental device, how thick it is and everything. You've hit on my absolutely favorite topic. It's this tongue thing. I do like this. What it is, when people, this gets into the scalloping of the tongue. When the tongue is scalloped, they're holding the tongue in the floor of their mouth so they can breathe through their mouth because they're non-nasal breathers. They can't breathe through their nose, so they breathe through their mouth, and that's the reason why it's scalloped. It's interesting, and we brought up China a little bit. In their traditional Chinese medicine, when you see the scalloped tongue, they say there's an absence of, I think they pronounce it Qi, Q-I. And what that means, the life energy has been evacuated from the body, is what that means.
Right.
Just Qi. Is that how you say it?
I think so.
It's the absence of the body energy. And so you're not getting the benefits of nasal breathing. And with nasal breathing, you get the nitric oxide, which is a signaling device to lower blood pressure. It causes red blood cells to release more oxygen. And you also sterilize the airway more completely and, for bacteria and whatever. So the best place for the tongue is not in the throat. It's in the mouth or in the oral cavity, wherever you can find a place to put it. And there's more nerve tissue in the tongue than there is in the bottom half of the body. So the tongue why does it have all that nerve tissue? Well, it has it also, it knows what to do. It can contort itself to any shape. That's the reason why you get the little scalloping on the side of the tongue. The tongue is trying to shove every little cell away from the back of the throat. And so the idea, if the tongue is up and forward, it's taking up the least amount of room in the airway, and that's what I look for.
Okay. And so is that is that a regularly occurring issue with a patient? For example, when you have a patient fitted for OAT, do you have to give them, let's call them tongue exercises or tongue instructions where you say, I want you to be thinking about trying to place the tongue in this position to see if you can get comfortable in this position?
You ask the greatest questions. It's so basic. We don't tell them anything. We've tried it both ways. Mm-hmm. And what's really interesting is you get the airway open so they can breathe through their nose, and they establish nasal breathing. That tongue comes right up and forward. It does exactly what you want it to do. They don't need to exercise it. Now, there's a lot of controversy on that because then it gets into the myofunctional therapies and all those things that people talk about. And that may be very helpful, and it may make it occur more quickly. Mm-hmm. But the fact of the matter is that most of our patients, once they were titrated correctly, wore nasal breathers when they got done, which I was amazed at without any instruction. I have a very good friend. He's the only person that I know that's kept data on this. Mm-hmm. And he puts a little dot on the appliance and tells the patient to hold their tongue up against this. And he's gotten remarkable results by having patients do exercises. So that may be very valid, but I don't do that. Could I say one more thing before we move on? This is so cool. I love when something ancient works. Right. Because we just didn't land on this planet. Have an iPhone in our hand. And there was a study done in Sweden about 3 or 4 years ago. I forget the author. I quote it all the time, and I can't remember the author's name right now. But anyway, what he found is that if you hum, you produce 15 times the amount of nitric oxide as you do normally. Yeah. So what do the Buddhist monks sit there and do hours on end? But they do their alms. Right. And so what is that going to do? You're getting 15 times more nitric oxide. You're going to lower your blood pressure. You're going to get more oxygenation, and you are going to get the enlightenment that they're looking for. And I find it extremely interesting. By nasal breathing, they can actually change the heart rate. They said that's the meditation. You can change heart rate with meditation. I believe that because you establish nasal breathing and you're using the nitric oxide to do that with. Mm-hmm. So I find all that very interesting because, people had sleep apnea for a lot longer than you and I have been around, and they found ways of doing it, but we've lost a lot of the traditional ways.
Right.